I have nothing to disclose. So liver resection, I think I don't need to educate oncologists about colon cancer, so I'm going to skip this one. However, when surgery was introduced for metastatectomy back in the early 1900s, this was a weird discussion. I actually remember during my residency program, which wasn't long ago, we still were counting the number of lesions and sizing them before deciding to go ahead for resection of metastatectomy. And I remember very well oncologists with us in the tumor board would say, spread it, what are you doing? So I think over time, in the past decade or so, selective liver resection for patients with colorectal cancer liver mets have clearly defined a superior survival outcome, and this has been reported with large cohorts of patients, started a lot with many centers across the world, European states, Jernagian, followed by Fong, who generated the first risk stratification score back in 1999. So it's nothing new. And back then they said, well, some patients don't really survive 5 years, even if you do whatever you can and resect them. If they had high CEA and the lymph nodes were positive and the lesions were above 5 centimeters. This is back in 1999, not so long ago. And then Europeans and Adam and his group from France start saying, well, you could go back and take them again. So you could re-resect recurrences and you have amazing survival. And so over and over, multiple publications came to prove the superior effect of metastatectomy over just chemotherapy in colon cancer liver metastases. And even we started pushing the boundaries. Why single lesion? Why 5 centimeter? Why 3 lesion less than 3 centimeters? So we start pushing the boundaries. Let's do a right hepatectomy for multiple lesions. Let's do an extended resections, which means you're taking more than one just lobe, either right or left. You're taking right plus or left plus. We call it extended resections. And yet again, there is reasonable morbidity and mortality with a survival benefit reported by many groups, which created a whole change in the paradigm of what is the criteria for resectability, whom we resect, whom we not. In the old criteria, we based a lot on how many, what's the size, is it both sides of the liver, one side of the liver, is it outside the liver or not outside the liver? And we moved to that to, can we just take it off? Irrespective, where are they, how many they are, how big are they, and so on. And so this new criteria for definition made it even more vague to define what is resectability. And that even compounded more on our clinical trials and publications, because what I define as a resectable, someone else would define it unresectable. And so that created a few years of confusion, which led to the discussions of let's standardize, let's talk about actual volumes. Let's talk about what is the real volume of the liver, how many we could leave, how many we should take. And that was a work that was led by MD Anderson, Eddie Abdullah and his group, and actually start talking about, so what is, do our livers always the same? Are they the same size? Is the right and the left are equal? And that generated a lot of information about liver volumes. This was together simultaneously happening at the same time as also donor transplantation was happening at the same time, which also were emphasizing on size and volume, and realized that, yes, volumes in general are pretty much matching to your surface area. However, right and left are different from one patient to another. And then that started to redefine what is an extended liver resection by, so what is the remnant liver? What is going to stay? So the discussion was, what is going to be removed? Now the discussion is, what is going to stay? And there's so many, again, a few publications were discussing how much that could be left. And the key answer is, what is the value of the hepatocytes that are staying? So now we got into a third dimension of defining what is, how much we can take, is what is the actual value and quality of the hepatocytes. And so in a normal liver function, pretty much every liver surgeon agrees 30% is very safe. Some pushed it to 20%, some went to 25%. It was a nice paper written by Pierre Clavian, back in 2007, I think. It was lessons learned from transplantation liver resections, and emphasized the idea of 30% is probably safe. And so that created also how we gonna measure the future liver remnant. Also, because the volumes were coming out in the literature so quickly, there were actually many ways to calculate liver volume. And pretty much today, most people adopted MD Anderson volume criteria that Nicola Botti did in his group, and it's based on volumetric analysis. And now most of our CT scans can actually do that pretty much easy. In my fellowship, I used to do volume calculation myself on the scanner. That takes 45 minutes back then. So from there, we realized, you see how the history moved. The history moved very quickly from the 1940, when the first crazy liver surgeons started resecting metastases, till now in 2018, where we say, okay, if you can remove it, go ahead, remove it. Make sure you have future liver remnant that can sustain survival, and do your best. And so we went to the next dimension. So how can we improve the future liver remnant? How can I increase that number to make sure that everyone is becoming resectable? And so that led us to 3 different research interests, and one very related to you, which is the use of pre-operative chemotherapy or neoadjuvant chemotherapy to shrink the size of the tumor, which allows more space of the liver to be left behind. The radiation intervention radiologists start saying, oh, we can ablate some of these lesions, so you don't have to go and resect everything. We can give you a nice removal of tumor mass without, losing a lot of hepatocytes. We ourselves, with the work with intervention radiologists, start looking into how to increase the size of the liver preoperatively. So we start talking about portal vein embolizations, hepatic vein embolizations, stage resections, ALPS. So we start pushing the boundaries then. I don't want to, I'm trying to not to go into the details of surgical resections, but we have trying to push the boundaries, and the most recent is the ALPS, which is the live resection of the liver, a staged live resection of the liver. And finally, which is pretty much new, is how to improve the quality. How can we improve the function of the hepatocytes? Because we said 30% in a completely normal hepatocytes. We realized over and over in time that sometimes we leave the 30% and it really doesn't work, and it fails, and the liver goes into failure. And sometimes we leave more than that and it still fails. Sometimes we leave less and patients do very well. And so we realized a lot that there's a component of liver function that is not being captured, and the use of simple liver function test that transplant guys use for child and mild actually is not relevant, because by the time your child is off or your mild score is off, your liver is way far from being resectable. And so I'll start one by one. I'll touch bases on all of these, and I'll try to reduce the ones you know more. So we start with preoperative chemotherapy. This has been also a very controversial point. One of the largest trials, there are many trials has been done. The most randomized control was back in 2006, I think. However, because of oncology and how fast they're moving with their treatments, and this is just a quick overview how you move from 5-FU, capecitabine, and irinotecan, oxali, cetuximab, bevacizumab, and now you have immune therapy for SRI mutated patients. We couldn't catch up on the clinical trial because we do a pre-op chemotherapy with FOLFOX. By the time the trial finished, FOLFOX is no longer the standard therapy. There's bevacizumab with it. By the time we did bevacizumab, you added cetuximab. By the time you add cetuximab, you're adding now PD-1 inhibitors. And so there has been a problem in that, because it's way easier to conduct a clinical trial in palliative patients than in neoadjuvant patients. Just sample by volume of patients. It's as simple as that. Not only that, before I go there, actually what I wanted to highlight here is patients or teams who gave chemotherapy before wanted to first make sure that this is not affecting negatively the patients. That was one first item, because we're always worried to operate and do a major resection after chemotherapy treatment without much of a time interval. And that even made it more complex when we introduced targeted therapy like bevacizumab and cetuximab. And the early reports, these were sometimes in the early 2000s, were showing actually there's no extra side effects, or there are no extra complications, but patients were actually achieving more likely resections. And I think this is the 2006 paper that came out in Lancet by Nordlinger and his group. And although it was a negative result, they did not show a survival benefit. It was, I think, a progression-free survival benefit only, which the oncologists, kind of stamped it in our faces for a very long time. But this was FOLFOX-based trial, only FOLFOX-based trial, and they gave only 4 to 6 cycles. But one important for us as a surgeon we loved about this paper was the safety of chemotherapy on hepatocytes when it's given around 4 to 6 cycles. And so the 4 to 6, everybody says 4 to 6, 4 to 6, actually came from this paper pretty much, because it was the only prospective randomized trial to show safety in livers. And again, our group had actually proved the same outcome on a separate publication back in 2010. And so the idea of chemotherapy, the only negative question came is disappearing lesions, because at certain cases there are number of small lesions that you give chemotherapy and they're gone. And then the question is, do you go after them? You don't go after them. And pretty much the literature is split halfway between should you go after them or should you not. So the ones said you should go after them, they said it's up to 70% there will be a recurrence. The ones said not, they said it's 30% recurrence. And it's basically how you look at the literature. There has been a lot of differences on calculating what is a response on radiology, especially when you start giving targeted therapy, because targeted therapy don't follow pretty much RECIST criteria, but they follow more of density criteria. And so that complicated what is the definition of pre-op complete response on radiology, and so it made it more difficult post-op. But at the same time, there has been groups pushing the idea of pre-localizing the tumors prior to giving chemotherapy. There has been multiple publications, most recently just a couple of years ago, from MD Anderson, that actually tried to localize all these, putting some small metal like the ones we use for prostate cancer in the liver to identify where are they, so that if they completely disappear, we'll be able to detect them in intraoperative ultrasound. So the first thing in chemotherapy is it safe? The second one, does it increase our complications? The third one, should we go after ghost lesions or disappearing lesions? How would we find them anyway? And this all work has been done. And a lot of people start talking about, this is one of the things I was telling you about in radiology. The problem with radiology response has been really not consistent. This came out in JAMA back in 2009, and basically saying that the classic RECIST criteria in liver metastasis when you give preoperative chemotherapy doesn't really reflect well the status of the tumors, which you use all the time engaging your should you continue the chemo? Should you go to a second line? Should we stop? Should we continue? Unfortunately, in the liver, there is a compounded problem by the targeted therapy. There are many patients who just have same size, so it looks like a stable disease. However, a complete hypodensity in the disease, which indicate complete that some of these lesions were actually in pathology had 0 tumors in it, but in radiology they still looked like a lesion. And so that led to pathological criteria, which is kind of after the fact. So I think we spent some time there to identify what is a response, what's not a response, and that hence the difficulty of doing clinical trials, because you really, the targets that you're looking for, if it's only survival, it takes long time to do, and by the time you finish it, the chemotherapy change. If you're looking for early outcomes like response, then how to measure it, that was another problem. And well enough, when we started to push the boundaries and we tried to bring patients to resectability and waited for first line and second line chemo, we start seeing some bad effects from chemotherapy. So the shape in the top, need water. But steroids. That's not what I give. So in the first picture is classic what we call blue liver. This is oxaliplatin. That's how it looks when you do this. When you enter the OR and see a liver like the top or the bottom, and your excitement for the surgery goes down by 20%. Your stress goes down, up by 50%, because these livers really break down. They're very difficult. They ooze like no tomorrow, and they fracture easy in your hand, and then you want to kill the person in front of you, and he wants to kill you too, and so it becomes really harsh. The one at the bottom is classic of irinotecan, which we call the yellow liver or cash. Now they have a different name for it. So these are side effects of chemotherapy, prolonged chemotherapy on the liver, which makes resectability and the whole definition of future liver remnant goes off the windows. Then we started the ablative technique. So in chemotherapy, preoperative chemotherapy, nothing was really conclusive. We know that there's a progression-free survival benefit that is published in Lancet as a randomized trial. We know we can make some lesions disappear, and so that will help us in resecting potentially more. The question is, should you go back to these or not? That's a good question. We know it's safe as long as you don't exceed 6 cycles. 4 to 6 is the magic word. We know that Avastin is fine. We're pretty much against cetuximab for now, since the last publication was not showing any survival benefit, but in the contrary, maybe even worse. We're not sure why. But we know if we resect them, we do well, so we're pushing that forward. So then the second way to try to resect more and be able to keep more livers is by the ablative techniques. And so the interventional radiology have something that is available to them, and they have different toys to play with. I put here radiofrequency ablation because they're more well published and demonstrated in the literature, but they have actually different toys. They have microwave ablations, they have ethanol injections, and in the RFA itself, there are different machines with different technologies. So I don't want to go into that because then we'll spend the whole day talking about this. But the concept is, and this has been very consistent, not only in colorectal cancer myths, but also in other cancers of the liver that we do the same thing for, which is hepatocellular carcinoma, that anything that less than 3 centimeters, probably the radiologist can take care of it with a very reasonable control and survival benefit. And so that is and what's the benefit over surgery is if you have bilateral diseases involving multiple lobes, you can then select some especially the ones located in the wrong place. So sometimes, and we just the tumor board yesterday we had exactly the same thing. We had a lot of lesions on the left, and then one centimeter lesion smacked between the right hepatic and the middle hepatic veins, which if you want to take it, you need to take a whole right liver. And it's the only thing on the right side, while you have 4 or 5 lesions on the left side. So then it was reasonable to just ablate that one and take the right and take the left separately as a resection. So RFA could be handy in trying to spare resecting normal livers if you can just burn that lesion and keep a large volume of the liver around it. The only proven, definitely 2 centimeters unless we're comfortable, 2 to 3 we start to be panicking, above 3 is no way so far. The second category is how to increase the volume pre-op. So how do we cheat the liver to grow before we even resect it? And in there, we start talking about portal vein embolizations, and some very few publications start talking about an additional hepatic vein embolization. And in there, basically, you're cheating the liver. You're taking away the blood supply that is going to the liver to make the liver think that that side is already gone, which will lead to hypertrophy on the other side, which will increase your future liver remnant. So we're embolizing the part that we will take out. And this has been published in the literature a few times, actually, where it started, I think we started talking about this in 2005 or 6. It was back then, we used to call it liver modeling. And fair enough, publication starts coming up as a reasonable way to increase future liver remnant. To do a portal embolization. This is a good example. This is a patient where the FLR was 20%. They embolized the right side. You could see actually the coils. Oops, nope, wrong. You see the coils in the on the right side These are the coils. So they're blocking the right hepatic vein so that the left liver increased in size. And so that achieved the future liver remnant the way we want. And that allowed us to do multiple resections. And this is one paper that came out of our group in 2012. And these were real cases where we no longer bilateral disease became a problem, where we can do the operation over 2 stages. So we take the left side out, we embolize the right. So we take the left, so we give chemotherapy 4 cycles. This is a paper that is indicated below by Mohammed Jamal. And so we took away the right side, we take away the left side after 4 cycles of chemo. Immediately in the post-op, like before the patient leaves, we do right portal vein embolization. We give them 1 cycle of chemo, Avastin-free. After surgery, we wait around 4 to 6 weeks, which allows the hypertrophy to happen. We go and take the right side out, and so the patient will live on segment 1 and 4 basically, and sometimes part of 4. So this was first reported in 2012, and then we actually reported the largest cohort of patients was 141, just published in PGS, and showed that their survival is as good as anyone else that we resected straightforward. And the ones who fails, because there's a failure rate, we did not negatively impact their survival. So it's not like, oh, if you fail, you're gonna go below the usual palliative chemotherapy. So when one fails, we're still very much equal to the palliative chemo. And so this was a good paper that came out and pushed the idea of stage resection. And so I will just mention here quickly the ALPS. The ALPS is doing exactly the same, however, in one setting. So instead of embolizing the portal vein, we're actually cutting them in the OR. So we do pretty much similar to a live donor. So we cut the entire liver. We make sure that the 2 sections are broken. But in live donation, then at the end, we cut the blood supply, take the liver to the recipient. In here, cut the blood supply, we keep it. We cut only the vein blood supply, keep the arterial and the venous. And then wait, usually 3-4 days, 5 days. The liver grows very fast. And then go back and do the second stage. The problem with this, and that's why I don't have any publications on it yet, or is still very controversial. The morbidity mortality seems to be very high. The indications to do this is still very vague, so I'm not talking about it today. Beyond this, the third category is so how to improve the quality, and this is very tricky. This is not what surgeons do. We're not good at it, at least. So, but now we're learning that we need to improve the quality of the hepatocytes. It's not only the volume; it's also the function. And there are many ways how to measure the function is coming up now. There's old ways that is being new, like NGCN green clearance and nuclear scan clearances and all that. But now more and more we're looking into, let's measure the ATPs in the hepatocytes. Let's measure their glycogen storages. Let's measure their cytokines, intrahepatic cytokines. So we're moving towards a more molecular way to measure what is the status of the function of the liver. We're looking at a combination of things. I'm not going to go into this because also it's very vast and not concluded yet. But it's worth to mention that we worked on a project back in late 2000. We put what we call the metabolic support regimen for the liver, and that was basically a combination of multiple things. So we used to give a loading carbohydrate dose prior to the surgery because, as you know, the hepatocytes are obligatory glucose dependent. And we usually keep them MPO the night before, so that by the time they enter the operation, their glycogen storage are all depleted. And glycogen is the source of energy for the hepatocytes to replicate. So it didn't make sense that we make them fast, deplete their glycogen, put them under stress, operate, cut the liver, and wait for it to regenerate after. So we gave them a preloading dose of carbohydrates intravenous because they can't eat. So they ate carbohydrate for a few days before, and then the night off they got the D10 water. And we continued that dextrose solution with an insulin clamp. So insulin clamp, and endocrinologists understand very well. We're giving high doses of insulin, so we're talking about it's 2 ml per kg per minute. It's really high. So you're 2 million. So you're at 7 to 8 units per minute drip for an adult. So it's high. And so, but we clamp it so that the way you clamp it is how endocrinologists used to calculate insulin resistance back then. You give the insulin standard and you take the dextrose until you reach a steady state. And the insulin basically is so high they will suppress endogenous insulin, and then you reach a clamp, and that will measure your insulin resistance. So we did the same thing intraoperative and the first 24 hours postoperative. We've had multiple publications. The first one was in nutrition, then in anesthesia and analgesia. Then we actually start looking at outcomes, and fair enough, we were able to reduce a lot of the complications post-op by this regimen. That was published in PGS, and we've had another basic science explanatory to what is really happening. So we measured the cytokines, we measured the ATPs, and we published on JCAM. So it works, but it's very labor intensive. You need an extra team beyond anesthesia and surgery to run this clamp in the OR, which is not easy to do. So 1 minute, perfect. So overall, the story is simple. The story is we can do it well with very low mortality and very good survival with reasonable morbidity. I mean, this may be high for some other surgeries, so you can't compare this to tonsils. But for us, we think it's pretty good, reasonable outcome. And we've published our data similar to everyone else. It looks like we have pretty much matching survival, although they tend to be younger patients in Saudi. Our survival wasn't as good as we would like it to be, but it was reasonable for a start. I think we're still shy of giving chemotherapy full dose. We have to say the surgery works, but it works best with chemotherapy. We've looked into the surgical outcomes themselves, and it looks also very reasonable. Like everyone else, our complication rate was around 39%. Our mortality was a little high, but there's a small sample size, so one additional patient could tip off the numbers. And as expected, once you go into liver failure, your mortality is pretty high. And this has been the discussion for a very long time, that if you go into liver failure, you're more likely to die. And not only that, you're more likely your survival benefit will be reduced. And so there's a lot of work on how to try to reduce morbidity and mortality post-op. There are a few things I wanted to touch. I talked about ALPS. Extrahepatic disease, the simple answer to this is if we take them out today, we push the envelope to take them out, whether they're in the lungs, in the peritoneum, in the abdomen, in the colon. If you can take them out, go ahead, take adrenals. Then that doesn't preclude or exclude liver resection. And the last thing is the liver first approach is something that we do in colorectal cancer mets, where we go with the liver first before the colon. And this has two indications at least to my experience. One is you have a critical large tumor that you worry if it grows, patients become unresectable. So we'll start with the liver. The second peculiar case is the rectum, where you had to give long course radiation therapy.